Welcome to This Week in Physical Medicine and Rehabilitation. This week we're covering 9 notable papers spanning innovations in neurorehabilitation, new approaches to managing complex pain and function, and a look at the systems and data that shape our practice. Let's dive in. We begin with innovations in neurorehabilitation for stroke recovery. A feasibility trial in Nature Medicine explored cervical epidural spinal cord stimulation for upper limb motor function in 7 individuals with chronic post-stroke hemiparesis and profound motor deficits. In this small cohort, there were no serious adverse events over the 4-week study period. The results were notable. With stimulation turned on, motor function improved immediately, with an average 32% increase in strength. Even with a very low dose of motor activity, just under 9 hours total, participants showed an average improvement of over 6 points on the Fogel-Meyer assessment by the end of the study. Spasticity also decreased in all participants. The authors note that spared sensory function may be a key factor in determining who responds best to this therapy, suggesting a potential future as a fully implantable neuroprosthetic. Complementing this primary study, a scoping review in the American Journal of Physical Medicine and Rehabilitation looked at the evidence for brain-computer interfaces, or BCIs, for gait rehabilitation after stroke. After reviewing 22 studies, the authors found that the most extensively investigated technology is an electroencephalography-based BCI integrated with functional electrical stimulation, or FES. This combination has demonstrated efficacy and safety in 3 randomized controlled trials. Other BCI systems, such as those integrated with mechanical devices or providing only visual feedback, are less studied, and those paired with exoskeletons have only shown technical feasibility so far. Together, these papers highlight a field ripe with technological promise, with some approaches like BCI-FES building a solid evidence base, while others, like cervical spinal cord stimulation, show exciting preliminary results that warrant larger trials. Next, we turn to the management of complex pain and function, with 3 papers offering new evidence for spinal cord injury, low back pain, and frozen shoulder. First, a pilot study in the Journal of Spinal Cord Medicine investigated a preemptive strategy for central neuropathic pain after spinal cord injury. 30 individuals with recent SCI participated, with 11 receiving preemptive low-dose pregabalin at 150 mg per day for 12 weeks. At the 12-week mark, the incidence of central neuropathic pain was just 9% in the pregabalin group, compared to over 52% in the untreated control group. The treatment also appeared to delay pain onset and reduce its severity, all with minimal adverse effects. This study suggests that early, low-dose pregabalin could be a valuable tool to prevent or mitigate one of the most challenging complications of SCI. For the ubiquitous problem of low back pain, the PAC-BACK randomized trial in JAMA Internal Medicine provides important guidance. The trial included 1,000 adults with acute or subacute low back pain who were at high risk for developing a chronic problem. It compared spinal manipulation, clinician-supported biopsychosocial self-management, a combination of the two, and standard medical care. At 1 year, clinician-supported self-management resulted in a lower pain impact score compared to medical care. While the absolute difference was small, the self-management group also had a higher proportion of responders and better scores on most secondary outcomes. Critically, spinal manipulation therapy was not found to be any better than medical care, and adding it to supported self-management provided no additional benefit. The clinical implication is clear. For these at-risk patients, our efforts are best spent on supported self-management that addresses psychosocial factors. Rounding out this theme, a randomized controlled trial in the Archives of Physical Medicine and Rehabilitation addressed a common clinical question for primary frozen shoulder, platelet-rich plasma versus corticosteroids. 90 patients were randomized to receive ultrasound-guided injections of either PRP, corticosteroid, or normal saline, all in conjunction with physical therapy. The results were definitive. The corticosteroid group showed significantly greater improvements in pain, disability, and range of motion compared to the PRP group. These superior effects were evident at the 1-month follow-up and persisted for the full 6 months of the study. While all groups improved with physical therapy, this study provides strong evidence to favor corticosteroid injections over PRP for treating primary frozen shoulder. Finally, we look at 4 papers that examine our systems of care, who can access them, and how we can better predict outcomes. First, from the Archives of Physical Medicine and Rehabilitation, a study on bone-anchored prosthesis offers a new perspective on transfemoral amputation. Researchers followed 16 individuals with severe socket-related problems who underwent single-stage osseointegration. After 12 months, their prosthesis wear time increased from 0 to nearly 14 hours a day. Their 6-minute walk distance improved significantly, and their pain scores dropped from 6.5 to 1.8 on a visual analog scale. When compared to a separate cohort of 21 high-functioning users of traditional socket-suspended prostheses, the osseointegration group had similar walking distance and quality of life, but reported significantly less pain. The findings suggest that for patients struggling with socket intolerance, osseointegration can level the playing field, restoring high function while reducing pain. Focusing on the crucial role of the care team, a randomized trial in the Journal of Spinal Cord Medicine evaluated a telehealth program for new caregivers of individuals with spinal cord injury. The Transition Assistance Program, or TAP, combined structured education with supportive problem solving over 5 sessions. In this trial of 31 dyads, caregivers who participated in TAP reported higher quality of caregiving compared to the usual care group, a finding that was statistically significant with a large effect size. While other outcomes showed favorable trends, they did not reach statistical significance in this small study, supporting the need for larger-scale trials of this promising telehealth intervention. Next, a study from the Archives of Physical Medicine and Rehabilitation demonstrates how machine learning can aid prognostication in traumatic brain injury. Researchers developed a model to predict favorable standing ability at discharge for 248 patients with moderate to severe TBI. Using variables available early in the hospital course, the model achieved high accuracy with an area under the curve of 0.85. Importantly, the most influential predictors included not only non-modifiable factors like age, but also modifiable ones like duration of intubation and early mobilization. This highlights the potential of such a tool to not only provide individualized prognosis, but also to support data-driven quality improvement in the ICU. Providing a critical big-picture context for all these interventions is a scoping review, also in Archives of Physical Medicine and Rehabilitation, on equitable access to rehabilitation services. After analyzing over 200 studies, the authors found an abundance of literature demonstrating disparities in access, with most research originating from the United States, Australia, and Canada. However, they found very little research focused on interventions to actually improve access. The most commonly reported barriers were the cost of services and transportation. This review serves as a powerful call to action for the field to move beyond simply documenting inequities and toward designing and testing solutions to address these structural determinants of health. If you only have time for one paper this week, make it the PAC-BACK trial on preventing chronic low back pain. This large factorial RCT provides strong evidence that for at-risk patients, our focus should be on clinician-supported biopsychosocial self-management, as spinal manipulation did not provide a benefit over standard medical care. Here are the key takeaways from this week in physical medicine and rehabilitation. First, for at-risk acute or subacute low back pain, prioritize clinician-supported biopsychosocial self-management. A large trial showed it reduces long-term pain impact more than standard medical care, while spinal manipulation did not. Second, for primary frozen shoulder, a single-blinded RCT confirms that ultrasound-guided corticosteroid injection provides superior pain relief and functional improvement compared to PRP, with benefits lasting 6 months. Third, in spinal cord injury, consider early low-dose preemptive pregabalin, as a pilot study suggests it may prevent or delay the onset of central neuropathic pain. And for new SCI caregivers, a structured telehealth support program can improve their perceived quality of caregiving. Fourth, advanced neurotechnologies continue to show promise. A small feasibility trial showed cervical spinal cord stimulation can immediately improve upper limb function post-stroke, while a review highlights emerging evidence for brain-computer interfaces in gait rehabilitation. Finally, data and technology can drive better care. A new machine learning model can accurately predict standing ability after TBI, using factors like early mobilization, and bone-anchored prostheses can restore high function and reduce pain for transfemoral amputees with socket issues. However, a major review reminds us that we must also address systemic barriers like cost and transportation to ensure equitable access to these services. That's your roundup for this week in physical medicine and rehabilitation. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.